specific subject matter experts in our fall domains, and also some critical new partners who we collaborate in the work. So welcome, everybody. Again, we'll be starting 3 after to make the best use of time. Okay, we have a lot to cover. I am going to come on camera now just to so you all can recognize me and know me. Again, my name is Sarah DeSilva. I have the honor of being the Director of Terminology for the Gravity Project. We have a lot of exciting things to do and discuss today. Unusual, we've been actually working throughout the summer. So for those of you who have been attending the program classification and program enhancements work, an update on that coming very shortly, but this is the formal kickoff of our fall domain cycle for the Gravity terminology curation process on language barriers and incarceration status. And then an update and orientation on coding for food, as we'll be addressing each of these areas over the course of the fall of 2024. Next slide. And subject matter experts for all of them are on the call, so it's great. So we will be having more individuals join us, I imagine, but so as we come in, we do ask that you start muted, but we have a very robust conversation throughout the call. So once we are all done putting our names and entities in the chat, please just put any comments in the chat, and we try to stop any conversation to any presentation to have a conversation and facilitate feedback. There's also plenty of times and pauses for questions. This is kind of a very high level administrative call because there's just a lot of new stuff to cover and some kickoff elements to cover. But in general, just know that your voices are welcome and we want to hear from you. So if you have any questions, raise your hand and we will try to get to you even if we have not reached the question element yet. As per usual, please send chats to everybody. If people send chats directly to me, they are likely to be read aloud because it can be difficult for me to discern everyone chat from a personal chat. So next slide. This is a common slide that we have to start with as a standards development process and part of HL7. So at Gravity Project, participants have a responsibility to comply fully with federal and state antitrust laws. So when we are speaking in this space, we have to, or providing written communication in the chat, we shall refrain from any discussion which may provide the basis for an inference that they've been agreed to take an action relating to prices, services, production, and allocation of markets, or any other matter having a market effect. So just be aware and mindful that you are speaking in a public place and antitrust practices apply as we go through our conversations today. Next slide. There's a lot of Sarahs on here, but hopefully given the amazing amount of subject matter experts I already see in the call, the Sarah is just a placeholder, and our SMEs and our leaders of each of these different areas can come in and speak and be the wiser members of the collective than I am on each of the topics we're going to be addressing today. Welcome first, and then we have some pretty exciting updates on the fall 2024 plan. So we're going to be getting into that. We're going to do an orientation on coding for food. I do see my dear friends, Katie and Kristen, on the call. So as we have been long advertising, we are going to be doing work on coding for food this fall. The kickoff was last year, but we're going to touch on it again and tell you all the work of the next weeks. We have then our formal kickoff for language barriers and incarceration status. We have an amazing array of subject matter experts and some open spots for a subject matter expert of reference we'll talk about shortly. As per custom, we have some all domain revisions. So if in our enhancements work and evaluating new terminology releases, we find concepts that we feel like should be in our value sets, but they haven't been reviewed by you all, we bring them to the meeting for review. And then Hamali will talk about updates in our value sets from our June scheduled value set update, right? So we do that formally in June and December, so all of you can know as you're working the implementation, and then we'll assign homework. Very late, long, it's a long agenda. If I look a little tuckered, that's why. Next slide. Okay, announcements. Next slide. We just want to make sure that everybody is aware of updating your email preferences. This is an initiative we've been working on over the summer as we work to more streamlined listservs and communication strategies. The unique nature of this group means that sometimes entities sign up for a domain and then they leave, and we want to make it easier for entities to like join and manage their emails so you're not getting a sea of emails for years and years. So the hyperlink has been dropped into the chats for you to update email preferences, and you can pick any of the work streams. So Gravity has a few work streams. We'll talk more about that in a second. So you can pick the ones that work for you. And we hope that you stay connected to the terminology work stream in our small but mighty little crew. Next slide. The technical work stream, as usual, meets Wednesdays 1 to 2 Eastern Standard Time every other week. The implementation work stream is on pause for August. We take an August holiday, and then we are reconvening on September 26th for the fall. And so join us again. It's the last Thursday of every month, and we'll see you on September 26th. Next slide. Any questions on the agenda or announcements? Okay, onward. Next slide. So because we have some new members, we are going to do a brief overview. Some of you are very familiar with Gravity Project, but it is important just to give a level setting. So what is Gravity Project? We are a collaborative initiative, and you are the collaborative, with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide. We would not be able to do what we do without our amazing members. And so we have a governing body that includes our members who help support the project and designated critical experts who we would not be able to do our work without their expertise. And they are the governing bodies of what we do in Gravity from a prioritization and a strategy perspective. So thank you, all of our members and sponsors and partners. We would not do what we do without you. Next slide. This is the timeline. We might eventually have to get a different slide. For those of you who do not know about our origin story, we kicked off in after a national convening in 2017 in DC, really trying to figure out the state of the science regarding data to address the social determinants of health. I had the honor of being there in 2017, and then shortly after, supported with the UCSF, the University of San Francisco, California, University of California, San Francisco, Social Intervention Research and Evaluation Network, SIREN, in partnership with EMI advisors, and I was there as well, and with Robert Wood Johnson Funds, kicked off the Gravity Project to address data gaps and data standardization for social determinants of health. Over the course of our years now, we've addressed 20 domains, 21. Suddenly I'm forgetting the count. You saw that 2021 was a big year. And so 2024 is utility and security, incarceration status, and language barriers. We also work on the exchange standard. So as we're developing the terminology on the top, we also develop the FHIR exchange standard in order to exchange information, and all of this in the kind of comprehensive view of the interconnectedness of health and social care as we address social determinants of health. So considering social care expertise and everything that we do, and in the designs that we developed for exchange because we have to. Next slide. So this is our roadmap. It's well known to many of you. So here we are kicking off language barriers. Our technical work stream is working on the ballot to align with US Core 6.1. Coding4Food is only dotted because we're in the final phases of contracting, but you will see that we're orienting you all and we're starting the work, and we will be coming back to you live when we have our subject matter expert work groups, bringing back information aligned with that work. And then we have our Infinity group on pause, but everything is very, very busy over in the Gravity world. And we are right now, we are very, very excited to kick off the language barriers and incarceration status domain and give you an update on Coding4Food, which is the subject of today. Next slide. Just want to make sure everyone's aware again on the Gravity data use principles. These ground everything that we do. It's important when you think about data development and data implementation and data governance, and we just weave it through our perspective always. They are improving personal health outcomes, improving population health equity, ensuring personal control, designing appropriate solutions, ensuring accountability, and very importantly, when we consider the domains we have today, and pretty much all of our domains, but thinking about today specifically, the principle of preventing, reducing, and remediating harm. You can always find those principles on our Confluence, and they're available in the chat. Next slide. Any questions on the general roadmap or anything that I've covered so far? Looks like we're doing pretty good. Okay, we're about to get into the meat. Next slide. All right, so what we do in terminology. Next slide. So important grounding before we get into the work is that this is kind of, this is definitely a part of our work in the spring, but going forward, Gravity Project and LOINC, which is that one of the data standards and health data standards at Registry. So this is the terminology. LOINC is the master of the terminology that we use for all of our instruments, our screening instruments, and questions and answers. So, if you want to be a subject matter expert in language access, please just send an email to gravityproject@hl7.org, and Sarah Bahal will put that in there. We actually have a gap and we're hoping to fill, so come, please, and then just send us your CV or your description of why. Thank you, Joshua. So in this partnership that we have with Registry, again, which is the steward of LOINC, which is the terminology of our assessment instruments, we have a 4-year partnership, 2024 to 2027, to make significant advances in social risk terminology. Thank you, Registry Foundation. So this includes addressing prioritized new social risk domains through this process that we have here. And this is what is supporting language barriers and incarceration status. And that formal open consensus public process with very distinct phases is called the terminology curation process. And it also ensures completion of prior domain terminology submissions. So we are very, very grateful for the support of the Registry Foundation. It stabilizes terminology development for until 2027. And just noting that it comes, the support's from Registry, but we operate independently, and the views of Registry Foundation are not necessarily the views of everything that's happening here. That's just that caveat that you do whenever you get a grant. But thank you so much to our partners at Registry for their long-going partnership in LOINC terminology development, and also for underwriting and supporting through the Registry Foundation 4 years of terminology work. So thank you, Registry friends. For those of you who've been around at Gravity for a while, you can remember, there were times we had to sunset terminology development as we awaited further funding. So with the support, we are steady 2 domains every 6 months for the next few years. So thank you, thank you. Next slide. That process that I mentioned is this process. And for anyone who's a new subject matter expert or anyone new to the community, this is how we do what we do. So when we say the formal process, this is it. So over the course of the summer, and really for many of us, who've been working on this, we've been doing pre-work for months. Like I would say some of these domains we've been working on since January or even 2023. So we do a formal pre-work process, identifying subject matter experts, reviewing the literature, making sure everything is aligned. And then we meet with you all. So here we are, August 8th is the start, and we are going to be doing our collective identification phase. And then we have a formal consensus end-to-end review, and then a formal consensus vote. And then the Gravity Terminology team analyzes gaps and develops terminology to address those gaps. And this is the primary process that addressed that call to arms that we noted in DC in 2017. We needed standardized language. We needed to address gaps with critical programs and problems and goals. And so this is the process that we've created over the course of the last few years. It's evidence-based because it's grounded in literature and all the subject matter experts we have on the call, and there's a lot of them. And then it's consensus driven, and that's where all of you come in. And we always make sure, as I mentioned, that it's what we call semantically consistent, right? We recognize that healthcare terminology is late to the game in naming many of the critical concerns that have been well known by social care experts and social care standards for a long time. So we match and marry them whenever we can, and just borrow and bring in and center their knowledge in our terminology development. And then, of course, just from a social justice framework, it's principled. So we ground ourselves in the ethics of data justice and social justice in everything that we do. So this is, again, the kickoff. We kick off another one in February, and this is the process that we'll be partnering with Registry on until 2027. So 2 new domains every 6-month cycle until 2027. Any questions on this? Anyone who's new to this? Okay. It's just like, and it'll become more familiar as we go forward. And each of these different icons go through our work. So right now we're in Identify, you're going to see that icon. And then when we switch to end-to-end review, you're actually going to see these same names go into our schedule very, very shortly. Next slide. What we make is, this is a very small snapshot of it. You heard me talk about LOINC terminology. So that's the encoding, that the terminology we use to support questions and answers. So over the course of our work, we'll be identifying the questions and answers we use to identify individuals with incarceration history or present incarceration or recent release. We'll be identifying the questions and answers that are important for identifying language and communication barriers, and then encoding them in LOINC, right? And then we'll also be ensuring that we have the correct and evidence-based diagnoses to identify both the meta high dimension, incarceration, and all of the critical subdimensions that we talk about in our work, right? So those of you who are familiar know that when we have high-level concepts that represent the top-level concern, but we're very, very careful to build terminology as well that speaks to the individual measure of risk or an individual specific status within that domain. Like, for instance, we did that with housing instability, where each of the different subtypes of housing instability had a term, right? And that's because those are the different elements that assign different levels of risk and require different interventions. We also build goal statements because we are a social determinants of health project, and so you can't just be deficit-based. So we build where we're moving towards, and then we build in all of the critical programs for whatever domain we are referencing. And again, focusing on national terminology. So if there's no local programs are not our focus, but we try to aggregate up into ways to talk about things on a national scale. Any questions on this for anyone who's new? This is where we're headed at the end, but far bigger. All right. So far, no questions. I'm hoping that means that you all are with me. And if you have any questions, know that this is a open, welcoming space, and you can ask anything, and we'll be revisiting these concepts over time. Next slide. So part of what happens is after we build the terminology, we create curations of it, which are called value sets, so that those value sets can be used in any different number of use cases. So all of the diagnoses for food insecurity, all of the programs and interventions for food insecurity, and then those become the heart of implementation, of research, of quality measurement, of standards, right? So that collection and curation of that information in a value set is then leveraged by all kinds of different entities for different reasons. Like, you name the use case that it can be used for it. Again, this is one of the benefits of Gravity, because then you have multiple entities across the research and quality and clinical practice and social care practice trying to leverage the same concepts. So then we can really start to understand outcomes of our interventions. Next slide. All right. This is kind of exciting for anyone who's been around a bit. And so brace yourself. So Gravity has a lot to do fall 2024. I'm sure that you saw, right? So we have 2 new domains to address. Hi, Alfonso. Language
Yes,
barriers.
hi. Yes.
Hi.
Hi, Sarah. Thank you. Alfonso Rodriguez with the CDC. Just a quick question. And so once all of this is completed for the number of domains that the project is working on, what happens? Organizations voluntarily incorporate those domains? So what is going to happen with this? All of this work? Obviously it's useful to have standards, but this is not going to be a national requirement, right? It's going to be something that organization will voluntarily adopt, or how?
Yeah, I'm happy to answer that. There's a couple different ways. We call them regulations and drivers, right? So there's not on this slide, but happy to discuss it and welcome one of our subject matter experts in language barriers from the CDC. There's a couple different ways in which there are actually drivers to implement gravity standards, right? One of them is the base truth that all of the terminology we build at Gravity become part of what's called United States Core Data for Interoperability by Design. So in the simplest level, a health system has to be able, with a certified health record, has to be able to document the terms that we develop together. In addition, there are many state level drivers, like for instance, with a reentry waiver, right? A state might mandate that they use the value sets from the incarceration status build. We see that in some state-based implementations now, like states asking that anyone reporting on the measure align with gravity. And that's because on a national level, there's many other quality measures and drivers that align with gravity. These include quality measures, NCQA, special needs measure, like social needs measure, or the incoming CMS quality measures, right? So that you have EHR drivers, you have state-based drivers, you have, and you have national quality measure drivers. Those are specific to certain domains. But regarding language barriers, for example, one of the reasons why we're leaning into this is because it's been recognized across CDC and CMS that current standards for United States Core Data for Interoperability, which only are preferred language and interpreter needed, are insufficient. So in this instance, we're actually leaning into this as Gravity because the government has said, we need more. Gravity, please help us, right? So there's all of these different drivers that come in. And incidentally, I am the co-chair of the committee that determines data standards for the country, with the expectation that some of the knowledge that we build here gets funneled up through that process. Is that, Alfonso, was that a good answer?
Thank you. Very useful. Thank you very much. Appreciate it.
Anyone who knows any better, have anything? I hope that was a good answer for somebody. I think anyone else need any qualifications? I think I did an okay job. It's a little complex, but the good thing is Gravity's well positioned to assist, and we're actually looked to assist with these kinds of evidence-based, consensus, standard-based approaches that can be referenced in other regulations and drivers. Lucy? Hi, Lucy.
Hi, Sarah, and thank you, Rodrigo, for that question. And I've put something in the chat, and I just wanted to stress that the diffusion paths for Gravity are multiplying, and Gravity is, dare I say, only within the last, well, aside from trying to influence coding, Gravity has matured to the point where Gravity and everyone associated is realizing all of these paths and having to make decisions about which ones are likely to be the most effective. And I just wanted to let everybody here know that these paths exist, but influencing them takes ages.
Mhm.
Ages. And anything that the federal government decides to do to change anything or introduce anything that reflects Gravity work has to go into a rule. The rules have to go into the Federal Register. They have to, I mean, it's just one thing that you learn about these diffusion paths is how incredibly bureaucratic they are, with all good reasons and lots of reasonable history. But let's not be under the illusion that the minute we finish a domain to our satisfaction, that all of a sudden everybody's going to understand and use it. Thank you.
Lucy, the great thing is about, that's so wise, Lucy. The great thing is about our subject matter experts for this domain is many of them come from the area of regulatory and federal government, so they know that really well. Wait till we get to our SME list. But Lucy, that's a really great comment. And again, I'm sorry if I minimized that process because it's actually really important. All right. I think I answered the question, and I'm going to go back to this. So the important thing to note is we are accustomed to having an every other week meeting in order to address the depth of things that we need to address in this fall work. We are going to be having a weekly meeting with alternating topics. So language barriers and incarceration starting today. We'll meet every other week at this time, doing our classic normative new domain terminology development process. And the subject matter experts and community who want to be part of that process will gather here. Next week, and alternating every other week is a group of it basically has come, it's like maturation, is a topic that's really leaning into enhancing prior domains and leaning into specific use cases. So in that is really the terminology and considerations to support interventions, including reimbursement, right? So Coding4Food, which is the HCPC development process for those 3 early food as medicine critical deliverables, that will start formally next week, right? And it's going to be in the every other week alternating meeting. We have some internal meetings of work groups to do before we bring it to the public. And that will be coupled with our ongoing conversation on program classification and program documentation. Does that make sense? Like, we're going to be meeting every other week. We're going to be every week, but every other week on different topics. That's new, never happened before. Hope it feels okay. So this is the right place and the right week, and all of this will be advertised on the Confluence we're about to go through. If we go to next slide, I'm sure I promise it's going to make sense. For example, these are the dates for language barriers and incarceration status, right? So we have every other week per usual, finishing off at the end of November, right? And then next slide. For program enhancements, including Coding4Food, it starts on next week, like the 15th. And again, Coding4Food won't formally bring anything to the meeting until we have something to bring with our subject matter experts. But then it'll be every other week there. And again, it's all on the Confluence, and it's all because what we recognize is there's very different stakeholders who wanted to be in each of these different conversations. We also recognized it was too much for one call, frankly. So we are dividing, right? So it's like new domains, semantics, meaning, every other week starting today, program enhancements, reimbursement, use cases, classification, Coding4Food, every other week starting next week. Lucy, do you still have a question, or did your hand not come down? I'm guessing you didn't. Okay, perfect. Jonathan?
Hello, can you hear me?
Yes, I can.
So I have a couple of questions. So will it be the same Zoom meeting link that we're using today?
Yes.
Okay, and then I tried to jump on the IG work group call yesterday. Are they on hiatus? Do you know?
No, it did happen. I think, Himali, it happened, correct? You were there, I imagine. Maybe not. Jonathan, I'll get back to you on that. I'm pretty sure that the tech call happened yesterday.
It happened.
Yes. Okay.
Yeah, so maybe I just need a different registration link.
Yeah, so whenever you have a question regarding access, it's a general Gravity project at hl7.org. It gets filtered by me and others to the right people. But Jonathan, we'll get back to you.
Thank you.
Sorry, Sarah. Sorry, Sarah. I was trying to find my mute button with so many.
I
But
know,
thanks,
it's okay.
Elena.
I know. It's all right. It's all right. We'll figure it out. And again, if you ever are having a hard time, the links from the Confluence should work, right? If you didn't get the email or didn't get the reminder and you want to go to the tech meeting that you know is happening because you saw it on the HL7 calendar, the meetings page on the Gravity Confluence should be able to take you there. Quick, easy button. Okay. Any questions on the schedule change? I think we're feeling okay about it. I think it makes sense. Okay, I'm glad. Next slide. Next slide. All right, so again, it's this week, every other week. And if for those of you who are new subject matter experts, thank you so much for your patience as we sort through these very administrative things. We have an invested community of people who come to this call, so there's some orientation to do. So language barriers and history of incarceration status every other week from today. Program enhancements, including Coding4Food when ready, every other week starting next week. All right? Okay, go team. Next slide. As always, any of the materials that we develop here that are for your review are available on the Confluence, and this will be the revisiting slide. Coding for Food is classified as enhancements of food insecurity, right? It's underneath that bucket. So we started talking about it in 2019, a HICPIC code for medically tailored meals, and it just has taken a little bit. Thank you, Katie and Kristen, for all of your leadership. So Coding for Food is located under food insecurity, and language barriers and incarceration status are located at the bottom as new domains. And then anytime something's cross-domain, it's in cross-domain build, which is a new section. So program classification elements are there. If you ever get confused, just send us an email. We care about all of you. We want to make sure you have access. We are here. All right. Any questions on where to find materials? Again, this is just the kickoff, so nothing to find right now. Nothing to find. All right. Next slide. Any questions? Weekly meetings. Yay! Okay, Mike, I'll figure out what's going on in the registration. Thank you so much. All right, so note to team something about the registration for tech calls not working because a couple people didn't get reminders. Okay, next slide. All right. Okay, so Coding for Food Orientation. I saw Katie on the call. I think is Kristen on the call too? Next slide. We just wanted to give you all an update. Hi, Katie. For those of you who remember a year ago, Katie and Kristen were on the call talking about Coding for Food, and they've been working diligently over the course of that year, planning for and getting us support for the Coding for Food work and speaking about it all over the national ecosystem. There is a lot of interest in food as medicine and the Coding for Food initiative, just because of the White House focus on the anti-hunger initiative and because of the state of the science. So they really are like a roadshow. Katie and Kristen represent a cohort of national leaders in food as medicine. The collective is massive, as you'll see once we start bringing the subject matter experts to the fore. For the why, we wanted to just make sure that everyone reviewed the Coding for Food kickoff and introductory materials. We've updated them according to the newest materials that they've been sent over. Over the next weeks, what we're going to be doing, again, this is going to be, the Coding for Food is going to be in the next meeting. So not the language barriers and incarceration meeting, it's going to be in the Coding for Food and program enhancements meeting, right? So it'll be formally every other week, next week going on. Yeah, Lucy? Hi.
Yeah, Sarah, could you just in one sentence say why Coding for Food needs to be enhanced? Is this new technology, more food, different actors? What's going on to result in Gravity thinking this is important enough for your precious time?
I'm going to give a Gravity answer, and then my friend Katie will give a subject matter expert answer. It's a little bit weird because way back in the Wayback Machine, I used to be a food insecurity expert. I don't know if I am anymore. That was my job. But I'm going to say the highest level is that we have been knowing the support for food as medicine interventions that are standardized across the ecosystem, and the evidence to support why they help and why they matter has been well known for decades.
Right.
But we have not had discrete terminology to name them, get reimbursed for them, or support their delivery. So it took some time to get consensus that this needed to happen. It didn't take very much time because once Katie and Kristen put out the call, it had like last, a year and a half ago, it started to roll pretty quickly. But it's like the time is now because of all the different initiatives that leverage terminology to support food as medicine interventions, CalAIM, different waivers, the Medicare, HRSN covered services list. There's a million different things that point to specific food as medicine interventions. We do not have terminology to support them. It's a major gap. So that's the why, because we've always leaned into supporting terminology for domains when it matters, and this one matters, and here we are.
That's great. Thank you very much.
Katie, I stole your thunder. Go for
No,
it.
I love it. That was perfect. The only tiny thing I'll add to keep it short is, for example, Massachusetts and Massachusetts and California have just put out coding guidance for food as medicine interventions. They have the same service type and they are currently using state-specific coding guidance that is different. So we are seeing state-based bespoke solutions bubble up because there's so much desire at the state level and we have no official national consensus for billing codes. And so this project will get us to a place where we can actually bill for these services the appropriate way and then have matching claims data across the country, which will help in so many ways beyond streamlining and research. So that's my like very short reason for like why we're finally at this moment. Thank you, Sarah. And you're definitely still a food and security expert.
Thank you both. That's really, really helpful. And of course, what I suspected about Medicaid, which has been working up for this century. So good luck.
Okay, and there's more coming on innovative Medicaid models driving a need for terminology later. Okay, so we're going to be convening, we're addressing medically tailored meals, medically tailored groceries, and produce prescriptions first. Anyone in the ecosystem, these are the top ones that I see in my FQHC all the time. And then next cycle we'll be addressing 3 additional ones, and that will be winter and spring 2025. So we are convening the work groups. We'll formally kick off publicly with findings later on. Once we're, we'll ping that, but it'll just be segued in to the enhancements meeting that's kicking off next week. All right. Okay, next slide. So much. All right, take a breath. That was all of the new updates. That was the Coding for Food update. Katie, thank you for coming. Again, we're working furiously to try to get those work groups set up. There's lots of experts in those work groups, and so it's a little bit of a feat, but we'll get it done. We're now going to pivot into the formal normal kickoff, and we have 2 different domains we're covering. I see Gerardo. I see Alfonso. So in language barriers, I see Julio. I see our 3 subject matter experts for language barriers, and it was a little bit of a furious, and I'm saying not furious, a little bit of an intense slide development process, because in all of our SME coordination, I just want to note, our SMEs are fully authorized to interrupt, be wiser than me. It's a very high level kickoff today. Our first formal SME meeting is tomorrow. And then we'll be more deeply going into the evidence and the why and the background as we go forward. But because we had so much to address today, it's already 4:40 and we're just starting our kickoff. It's a high level concept today. And then the SMEs will be more formally centering their expertise and wisdom as we go forward, as you know they do. And welcome, SMEs, and thank you so much for your expertise. Next slide. So we always try to start with a general why, again, super high level, because there was a lot to cover today. So just of how we got here, the need for addressing language barriers grew out of our prior work on health literacy. Gerardo was actually at that call on like health. So thank you for driving that way back then, as we were working through concepts of adaptive devices and their role in health literacy and translation. It was just so critically clear that language barriers and communication access needed to be its own domain and thought of more carefully. So as with health literacy, we just want to know an equitable provision of care, a given community system or setting effectively meets the language and communication needs of any individual. That's the dream. And so inequity occurs and risks arise when the system or setting does not do this, right? Leading to delayed care, lack of preventative services, poor quality care, increased utilization, language-mediated concerns for health literacy, and decreased patient satisfaction. This is just some of the evidence about why this matters. Lucy, yeah?
Sarah, if you just want to comment about this under inequity occurs, using inappropriate people to translate.
Yeah.
Like children coming in with the parents and having to deal with, I don't know, sexual reproduction or completely inappropriate. So I don't know whether that notion or that fact is included in these concepts, but it isn't. Could you add it? And if it is, could you tell me where it is?
It's part of in the base standards, it's part of the class standards, but actually our subject matter experts might want to, I actually feel like, Carter, this is one of your areas of expertise, correct? Sorry to call you out. if any of our SMEs want to weigh in, you're welcome.
Yeah, that is correct. This is the standards, the cultural and linguistically appropriate standards, 5 to 8. There is a provision there where it indicates that individuals have to be properly qualified, and that family members, particularly minors, should not interpret or act as linguistic mediators in these encounters.
Yes, so, and if we go to the next slide, thank you so much. I really appreciate you piping in there. If we go to the
Thank
next
you.
slide. Yeah. So this is kind of like, again, and my apologies, we tried to convene on these slides before the meeting, and we didn't have a chance to. So this is the first lightest version of the expertise of our subject matter experts. But the base standard is the National Standard for Cultural and Linguistic Appropriate Services in Healthcare, the CLASS standards, and that's the standard that Gerardo was speaking to. And they specify many, many things, and there's a hyperlink to all the different specifications on them, and the resource will be on the Confluence for review, right? So that, thank you so much, Sarah. And they're also put in the chat. So Lucy, that's the specific answer to the base standards that are supposed to say that that's not what you just mentioned is not allowed, right? And then we also note that there's base data standards with the preferred language and interpreter needed being the current standard for certified health records, right? But there's gaps there, right? So the thing I wanted to state here, the thing I pulled forward was just the difference between base standards and the concept called language equity, which our subject matter experts will go much deeper into as we go forward. But language equity refers to the principle and practice of ensuring that every person, regardless of the language skills or preference, has equal access to information, resources, and opportunities to help them achieve their best health and overall well-being. Alfonso.
Yeah, no, thank you. I think that one area that I see a big gap is not just in receiving information, but also in participating in data collection activities. Because if language access is not provided, people who are not, English proficient are excluded from our data monitoring because they cannot participate and their needs are invisible. So I think that's an important aspect. And the other side, because to receive information, you need to know what are the needs, right? Particular needs. So that's another aspect I think that we hope we don't forget in terms of, collecting, participating in data collection activities. Equal opportunity. Yeah, thanks.
That's really important, Alfonso. Thank you. We talk a lot about that. I have the honor of co-chairing the HITAC. We talk a lot about like the who's at the table model from a social justice framework, right? So unless your model includes, is representative, then the outcomes cannot be, right? So thank you so much. So this is just a general, so we have the base standard, we have class there, and then anything else needs to say before we go into the next slide?
I just wanted to piggyback on what Alfonso just said, that the representativeness of individuals with limited English proficiency is also exacerbated by the fact that when there are research studies or projects in process, the perceived difficulty, excess of work, and perhaps excess of expenditures makes it more difficult for principal investigators or project directors to initiate a more diverse recruitment of individuals, regardless of the language that they speak.
Thank you so much. That's so important. There's a language equity. There's an equity element in there too. Any other thoughts before we go on to the next slide? Again, it's just thank you so much. We have 3 really brilliant subject matter experts, and there's a gap that we're hoping to fill in our yes. So Scott Stair from CMS is talking about AI as well, right? So we were across domains, actually. We were talking about Dr. Ruha Benjamin actually in history, incarceration status as well. But the bias, in algorithmic models that do not include primary language of reference are well known, right? We were talking, so Ruha, Dr. Benjamin came up in both of the different domains that we're addressing. She's a hero of mine. Next slide. We do want to, so these are our subject matter experts. Again, our first formal kickoff is next week. Thank you tomorrow. Thank you so much Dr. Alfonso Rodriguez Lenz, who is epidemiologist at Center for Disease Control and Prevention, Gerardo Lazaro, who's a health scientist at CDC, and Julio Vicente Talapierre. And is that the right way to say your last name, Julio? I hope
Yes,
so.
it is. Thank you.
Yes. Yes, at Centers for Disease Control and Prevention. So again, thank you so much to, so Gerardo has been a longtime member of Gravity. Thank you so much for coming back and elevating this domain. And thank you so much to the experts at CDC who will be helping us. And thank you to our friend, Christy Clark, who helped, who's a CDC rep on the operating committee. And then we do have, we're going to be meeting formally next week. I mean, tomorrow, I keep on saying that. It's been a long week. And I look forward to addressing language barriers and communication barriers over the course of our months with you all. Next slide. On the next slide, unless there's a delay. I don't know. Can you all see the next slide? I can't yet. Oh, there we go. Okay. One thing, I am coming to you from Vermont, so sometimes my internet is slow. So one thing we wanted to know from an equity perspective, we've been talking about this and have had a couple subject matter experts come to light, but we even had, Rosie was going to connect us to some with lived experience, but we still are seeking additional SMEs who can assist with representing and assessing and addressing non-spoken languages, including ASL, ISL, and those who communicate with adaptive devices. I have a couple leads out, but I'm not really content until we fill this gap. So these are specialists in augmentative and alternative communication devices, augmented and alternative communication strategies. This is largely driven through speech language pathologists. Lucy, you were hearkening to this, and I'll just let you know that we are laser focused on making sure that we fill this gap. We actually, I have like 3 meetings over the course of next week to try to get additional subject matter experts to fill this gap. But if you have anybody in your ecosystem that you know is a recognized subject matter expert in the area of augmentative and alternative communication, please let us know. I even have some local SLPs that I work with on a regular basis that I might just rope in, because I'm not content until we have that gap filled. And that was actually, again, part of what drove this domain, was talking about adaptive devices and health literacy and how critical they were. So anybody on the call who knows a subject matter expert in augmentative and alternative communication and expertise in addressing those with needs in non-spoken languages, please let us know. All right. I think any questions on language barriers? Again, high-level kickoff. More to come. We had to do the divide and conquer announcement today, so just high level, and we're doing more. This meeting will be just focused on language barriers and communication barriers and incarceration status going forward.
Sarah, quick question for the experts.
Yeah.
Are language barriers perceived to differ by age group within populations that in general have a language barrier, like children or teenagers or adults or elderly? Is that a dimension that's been investigated, or has it come up? I'm just suddenly wondering.
I can say that the research on perception of language barriers is certainly in need of further work. In the case of early ages, in particular, because they are usually the ones that acquire the language much faster than adults.
Exactly. That's what I was thinking.
Acquire it. Yes. And so typically, I would assume that the perception is that, and perhaps the body of literature indicates that there actually isn't enough research to discuss about this. I think that we are still primarily focused on counting and acknowledging the barriers, and needed research in like language acculturation, for example, is not even present at the level that it should, let alone perception of language barriers. There are some cases in which this perception is measured more coincidentally in pediatric institutions, which for the most part in the country are the ones that have the most robust language access programs in healthcare organizations. But it would be a very interesting way to increase the body of knowledge in this field.
That's fascinating. Thanks so much.
I do want to note, Alfonso, that the language equity definition that I borrowed came from Boston Children's Language Equity and Access Division. So, Hardo, just to elevate what you were saying, they have a whole division in equitable access in pediatrics in their hospital. So, thank you, Alfonso. Do you have a?
Yeah, thank you, Falava. That's a very good question, and I feel very humble. I don't know if I consider myself an expert on anything. I'm just learning in process like everybody else. But I think it's a very relevant issue for persons in the US who were born in countries where English is not the official or the primary language. And because children who come from those countries in the US very quickly adopt English. My children are a very perfect example, sometimes of their primary language, while the adults take a long time to achieve, English proficiency. So this is very, very relevant for immigrant refugee populations in the US. And by the way, that's one of the critical, related domains or data that I think should be collected, because also it's an indicator of culture. Even for English, you have somebody from Jamaica, even though English is the official language, or Trinidad and Tobago, and the language, accent, ability to understand American English and communicate, particularly adults, elderly, it can be a lot of difficulties. So I think that country of origin and the time in the US is another important, and obviously age those are important factors to consider when we're talking about language access.
Thank you so much. I really look forward to addressing the language barriers and communication barriers domain with all of you. Any other questions before we move on to our next high-level kickoff? We have all kinds of wonderful conversations coming up ahead of us. Julio, did you want to speak before we moved on?
Sure. So I'm just reflecting on what Gerardo and Alfonso just said. From our vantage point, we try to drive our recommendations based on the evidence, but to contribute to the previous question, most of our funding around language access has historically been flat or absent. So if funding drives research, there hasn't been much research on language access overall, much less at this level of granularity where you do subsets by either age, nationality, or acculturative development, 1 year versus 5 years versus 10 years, right? In the US. Given that it has been historically flat and the research tends to be very convenient based on whatever people are able to do in a particular circumstance like Boston, and Massachusetts is a great example. Hawaii also has some good examples, but they're spotty, right? And they're very context specific. What's sort of the evidentiary basis for how we move forward in the absence of existing evidence? Over.
Is that a question to us, or is that a rhetorical question? That seems like a rhetorical question. It seems like but I just want to make sure that I understand you correctly.
It is a question to this group in that I just want to be clear.
Yeah.
As we make comments and recommendations is the foundation for the support of those recommendations, the iterative process with the SMEs?
Yeah.
Okay, thank you.
Yes, because, and just from a state of comfort, I know that, like, this might be, you know, the subject matter experts are gathered for that purpose, right? That's why we convene you. And we're very accustomed at Gravity to representing concepts that are necessary from the inequity of it not being prioritized before. That is what we do, right? We lean into space, even the irony that Gravity had to be created a very short period of time ago because we couldn't name really fundamental problems, right? So we're very accustomed to, like, social isolation was a great example, homelessness is a great example, housing instability, where we lean in with our subject matter expertise to create space. And sometimes there is just like, there's a area that we're not able to address right now, but we know it's incoming, but we know it's iterative, and we lean on our subject matter experts to help guide us. And then hopefully the terminology and the data enables for like further research, and we highlight the need in this group. Julio, was that a good answer? Welcome to the work of Gravity. That's nice. All right, I know. Okay, fantastic. Any other questions? And then, you know, language and communication barriers and incarceration status are really intense domains to cover back to back. So are we ready to move on to incarceration status? Again, we're in very good company insofar as addressing, you know what, sorry, I get emotional. Anyone who's been here a while knows I do, but principles of data justice, and part of the reason why we created Gravity Project is the primary injustice is invisibility, right? Like not being able to be seen or named and have your story be told, right? So that is the fundamental injustice that we work on addressing here, is we work to be able to tell critical stories together. So grateful for all of you. All right. Any other questions? Yeah.
There's one more thought following from the last really important comment. As Gravity gets into realms that become more and more really important, and therefore have generated fewer dollars to study because a lot of people don't want this studied, maybe we can be thinking always of, in a conversation, we would say, put that on the whiteboard to talk about later, but maybe we should start thinking about pointing to problems we know exist, but there isn't enough evidence, so we can't have a standard.
Yeah.
But we don't forget about what those elements or observations are.
That sounds great, Lucy. We can hold ourselves accountable to that. And then we have lots of good friends to talk to about that as well. Fantastic. Any other questions before we move on to incarceration status? It is. All right. Thank you, subject matter experts. We really appreciate you. Looking forward to talking to you tomorrow. We have a couple of our incarceration subject matter experts have left the call because it's top of the hour, but there's a lot of SMEs on the call for this next domain as well. We look forward to addressing language barriers. And again, if you have an idea for a SME, a national SME, who can address specifically ways of identifying and intervening on those who require augmentative and alternative communication, please let us know. Next slide. All right, incarceration status. We have so many SMEs. We have a bunch of our SMEs, I think, hopefully, or do we only have, I think it's trying to figure out who are, we have Mayan, hello. Just making sure. Okay, so incarceration status, some of our subject matter experts had to step off, but we're gonna kick this off and then again, come back to you next week You are the last one standing, but you were the first one to raise the call. So just as a note, Mylan and Radha came up to me at the Academy Research meeting last year, wondering when we were going to address incarceration status, and here we are. So thank you for sticking around, Mylan. And then hopefully, because next time we're not going to be addressing so much administrative stuff, we'll be able to get into the meat. But Mylan, thanks for helping me because this is your area of reference. Next slide. All right, so incarceration status, this is the why grounding. Incarceration status is a domain within the realm of statuses that put individuals at risk of both health and social adverse outcomes. We say it that way because to recognize in an equitable society that status should not put you at risk, right? As with other statuses, the associated risk derives from the intersection of personal histories and structural barriers and biases. So incarcerated individuals have higher rates of all kinds of things. There's links and links and links and resources on the confluence, but mental health concerns, chronic conditions, substance use disorders, barriers to healthcare, both while incarcerated and upon reentry, and higher rates of the financial, social insecurities, including food insecurity, homelessness, housing instability, et cetera, et cetera, et cetera. And it's really important to note, and we were actually just talking about intersections in families prior, that incarceration is a health and social risk, not just to the individuals, but also their children and families and their social networks. And so by design, we'll be addressing this in our work. So not just identifying screening questions to identify an individual with this history of incarceration, but ensuring that we're looking at children and people that and social networks as well. Especially there's all kinds of the importance of screening for family member currently or historically incarcerated as one of the principal adverse child experiences elements. So just noting that that's going to be our approach. Milan, anything to say here else? Are you okay? We did review this morning. I just want to make sure that you're the last one standing.
No, I think that's an excellent overview.
Okay, great. Next slide. So just again, some high-level concepts related to our prior work. This is gravity. We've addressed these food insecurity before, right? But studies have shown formerly incarcerated people are twice as likely to experience food insecurity and 10 times more likely to experience homelessness in the general public. That should be gut-wrenching, okay? Not pictured on the following tables because we have some pictures for you, but understood is also the risk of housing instability as well, right? Next slide. Because pictures are nice, so these are the rates. This is the table indicating that the food insecurity rates. So formerly incarcerated people are twice as likely to experience food insecurity as a general population. This is data from 2019. And then we have a recent study by the Prison Policy Organization indicating homelessness rates among formerly incarcerated people, right? The data are very sobering. So you have the general public rates, and then you have the formerly incarcerated rates. Next slide. So one of the whys for our project, so the health risks and social risks of being currently or formerly incarcerated, we covered, right? So one of the things that escalated this and why Milan coming up to me a year ago at an Academy Health meeting suddenly escalated and prioritized this is because of work that's going around and going on in the national ecosystem. And Lucy, this goes back to Medicaid. Right, so there is a status called reentry status, which is the transition from prisons or jails back to the community. It's a status like that, a status in your pathway along incarceration. There's also phases in that, and I think this is directly pulled from our SME meeting this morning. So SME, thanks for helping us with the data. So there are 3 reentry phases. There's the institutional phase, which is a preparatory. There's structured reentry, which is 6 months pre-release to 30 days post-release, and then 3 is which is integration, which is 31 days post-release plus days. The reason why this is important, this reentry concept, is 95% of incarcerated persons will reenter the community, right? And then 2/3 of released persons nationally are reincarcerated within 3 years, right? So just as we focus on readmissions in clinical settings, focusing on stabilizing and supporting individuals who are reentering the community from histories of incarceration is critically important. Milan, anything to say there on the reentry topic?
Yeah, just to add briefly, just a little bit of context as well as to why this kind of moment is really a huge opportunity for healthcare providers. So individuals who are incarcerated in prisons and jails due to the Social Security Act of 1965, it included a clause called the Medicaid Inmate Exclusion Policy, which prevents the use of federal funds for healthcare reimbursement. So effectively, people, when they're actively incarcerated, are federally banned or blocked from using Medicaid. There's one exception for hospitalizations that are longer than 24 hours. But, if you think of, your standard medical care, there's a burden on states and counties to finance their own healthcare. And when we think about also access to healthcare and health insurance, in particular in healthcare financing in the community, there are a lot of regulatory standards and checks for healthcare quality that, because of financing being kind of really siloed for states and counties, those same quality standards don't necessarily apply. So there's a lot of variability in the quality of healthcare that's provided in jails and prisons, and that's part of also what drives the health disparities that we see among this population. And so these Medicaid 1115 waivers essentially are waiving that Medicaid inmate exclusion policy for a period of up to 90 days prior to release. And different states are doing different things. Like in my state, in New Hampshire, we've only asked for 45 days prior to release, but up to 90 days prior to release, Medicaid essentially can be turned on for individuals that are leaving from prison or jail settings. And there's a lot of complexity related to that, especially for jails where the release dates aren't always known in advance. So states will have a lot to work through on that, but definitely having terminology will be really helpful for standardizing and especially for being able to evaluate the impact of these waivers. And I'm especially hoping to hopefully create a path for ultimately reversing this Medicaid inmate exclusion policy that's creating so much disparity.
Here we go. That's using data for the good. Oh, Eddie, hi. Eddie, do you have anything? Eddie's another one of our subject matter experts. You're not the last one standing, Milan. You have a friend.
Really sorry. Some of my colleagues, including myself, we are in different meetings that we were in right now, so we couldn't join. So I'm here now. I'm just going to listen in.
You're great. Thanks for coming, Eddie.
Thank you.
Great. Okay. So next slide. Welcome. Okay, so this is a very busy slide. Oh, Julio, yes? I love one subject matter experts asking a question of another one. Or maybe just has thoughts. Julio?
So initially when I started hearing the presentation, I thought, so it's gonna just focus on post-incarceration, but then with Mila's explanation of what happens while you're incarcerated, I have to ask the question. So does this deal with recidivism at all, or does it only look at things at one particular time interval? In other words, after, or I mean, post-incarceration, or both? It sounds like it's starting to sound like it's both.
Yeah, so
Go for it, Milan. You go.
Oh no, I was going to say, and we were discussing also earlier in our SME meeting, and there's a table or a graph of a model that's coming up on the next slide. But incarceration is really one small slice of the criminal legal system, and the criminal legal system essentially is really like a system of systems or multiple different experiences that individuals can have from being in the community and arrest and being in a pre-trial or pre-adjudication status. They're moving through the court system and going through a sentencing process all the way through incarceration, reentry, and community supervision. And so I think tied to the waivers, I think that kind of our initial charge is to focus on developing terminology that can support especially like the evaluation of these waivers in the future. But there's so much more about so many other ways that the criminal legal system touches patients and that people can be exposed to it, as well as their families and communities, that there's really a lot of terminology that that we could work on hereafter, and that I hope we'll have the opportunity to.
Willie, was that a good answer? The answer is anything that matters, anything that's relevant and helps just tell the story is what we usually do. We did, of note, we peeled off one whole section because we wanted to focus on the cycle and process and directness of incarceration, but also we're going to show the sequential intercept model very, very shortly. And we did not adjust just general legal requirements like needing a help with a power of attorney to focus on this. But we really are making sure that we develop the terminology to support any of the statuses of risk and any of the dimensions of the meta domain of incarceration status, which includes present, historical, and therein. Is that helpful?
That does. You hit it. I was about to ask a question, but you
Oh, good.
you have addressed it. Yeah. Wow.
I'm good. I know it's good. It's yeah. And this is again what we do if we're accustomed to doing this. So this is just the and again, if it has to be, well, this is the adventure we're on for the next 4 months, 5 months. So this is just a really good example of the stated goals of Medicaid reentry waivers. Milan talked about them on the previous slide. But it's to increase coverage and continuity of coverage and appropriate service intake. And that was a really long phrase, so I just did ellipses. Improve access to services, improve transitions, improve coordination and communication, increase investments in healthcare related services, improve connections between carceral settings and community services, reduce, and again, here's some really clinical, again, this is reminiscent of like readmissions here, right? Reduce all-cause deaths in the near-term post-release and reduce number of ED visits and inpatient hospitalizations among recently incarcerated Medicaid beneficiaries, right? So we have that like really tangible quality goal, like the why are we doing this is like the health risks and the social risks, we talked about them. But these are the things that we feel like we hope we can influence with the waiver and hopefully with the undoing of the regulation, as Milan said, right? And so of note, again, the reason why the waivers are highlighted here is states came to us stating they did not have the data to support these waivers. And so they came to Gravity asking us to lean in. And it directly tied into Milan coming up to me at the ARM meeting. And I was like, Milan, let's talk about incarceration. Right. So this is why we're leading into it. So all of this, all of the goals of a reentry waiver require data that we currently don't have a standard for. So this is why we're here today. Any questions on that? Okay, next slide. 11. Thank you, Milan. So smart, brilliant. And again, this is a version of the crisis intercept model, the sequential intercept model, which basically talk about, again, I'm actually let the SMEs talk about it because we have for the purpose of the waiver, the term reentry might be limited, and our SMEs will help us over the course of the next months really go deeply into the complexity and nuances of the incarceration status domain, including all the statuses Milan was just talking about. It's represented on the model. Eddie, Milan, anyone want to unpack the community intercept model, a sequential intercept model at all? Sorry, I'm getting tongue twisted because I'm a little tired. Alfonso, do you have a question?
Yeah, just a comment. Again, I think that another important factor to also population to consider are immigration detention, because it has unique consequences for the detainee, but also for their family members who may be legally in the US and their father, mother, husband is deported or incarcerated for a long period of time. So I think that's another thing, important group, increasingly large population to detainees or people in the correctional facilities that I think need to be considered.
That is really important. And I do want to note, and all of our language barrier SMEs are going to be able to help with this, but migrant concepts in migrant health and migrant status and migrant justice are one of Gravity's future identified domains. And so I just want to note that that might be within that. Yes, 100%. Need to lean into that. And I want to note that maybe you can help us elevate that domain of reference.
Yeah. And I think we'll be happy to do that, but I think it's also very important to include it here because it sounds like the only, potential outcome for people in correction, the facilities in the US are either the parole or the probation or being released. And actually there is another one that is being deported. So this is why I think, yes, definitely having as a separate, it sound social domain is critical, but also incorporated as a cross-cutting, complicating or complex, or increasing the complexity in this, because otherwise it's ignored. The same thing for language. If you ever consider, country of birth for the person, culture, it will be ignored. So you cannot just relegate it to one separate because it's significantly interacting with this different flow that you have here. Otherwise, it's invisible.
Milan has a really good comment. Thank you so much, Alfonso. We hear you. Yes, we hear you. And Milan has a comment regarding that. Do you want to speak to it out loud or do you want to have it be in the chat?
Oh, sure. Yeah, I was just going to say that immigration detention, my understanding is usually under civil jurisdiction, not criminal jurisdiction, but absolutely agree. There's like a lot of co-location of immigrant detention centers within criminal legal centers, and so absolutely there's a lot of mix that happens. Although the rights, not that there are many, but the rights that are given to people who are incarcerated under the criminal legal jurisdiction, in my understanding, don't necessarily extend to individuals who are detained. So for example, like if there's a Supreme Court ruling that gives a right to adequate healthcare for individuals who are incarcerated, I don't believe that extends to those who are detained, which just really even more so highlights the need to make sure that we create terminology for that population. And if this is something that we want to incorporate within the incarceration status, I will say I do have a friend who focuses in this area, Chanel Diaz. She works with the ACLU, who I would love to recommend.
That sounds great.
Yeah, those are great points. And also, some states are making immigration issues criminal, like in Texas, for example. So I agree with you that it's becoming very integrated or, cross-cutting populations. And this is what's important to incorporate into these models.
Thank you so much. We're having a really important conversation today. I want to make sure that, so Julio, I hope the sequential intercept model, it was you, I think, who were talking about the, wondering about the type of incarceration status we were talking about. I hope the representation of the sequential intercept model in all of its different phases and stages and statuses helps the community be clear that we intend to look comprehensively.
Yeah, it does, particularly with the conversation that just ensued. So yeah.
Okay, great. Any other comments from our subject matter experts on this topic? I do want to note, we have addressed topics that brush like against some of the most significant injustices of our society and our culture in the past. Like we addressed intimate partner violence and elder abuse, right? And I just want to note that, just what we were just talking about is hard stuff, right? To have humans be, even Milan's comments about rights not being extended. It's a very emotional thing, and it's very hard to talk about. So just want everyone to understand that we all are going to be trying to take care of each other in this space and do it justice. And I'm not trying to have that word be a double entendre, but just know that the part of why it's hard is why it matters, right? So just make sure that you take care of yourself as we go forward, doing this critical work. And everyone knows, I mean, everyone who was here during a part of violence knows it was very intense, right? So thank you so much for sticking with us through this. Any other, I think this is the last slide for incarceration status. Next slide. Yes, and okay, the only thing I wanted to highlight again is very much tied into what I just mentioned. We were talking about the injustice of invisibility, right? And so there also is injustice that is possible when your data is made visible. Again, we were bringing up Dr. Benjamin before, Meredith Broussard, Safiya Noble, all of these heroes in data justice. There's also bias when your data is available. So, and we think about things like incarceration status being in the data stream, it's very important for us to think about the risk of that data being present in places where people can use it for harm. And so every single one of the SMEs that we've talked to so far are just making, we've reiterated our data principles, and we're going to make sure we're committed to them in our practice, and just making sure that we note capacities for bias when we're creating data solutions and think about consent and appropriate sharing. So I just want to make sure everyone's aware that is part of our MO at all times. Any other questions before we move on? Again, Milan and Eddie, thanks for being here. Language barriers, SMEs, thanks for, I did not plan for the intersection of this domain, but it's going to be a really powerful fall, and we're really grateful for all of your expertise. Anything else to say before we move on and assign homework? Actually, we're supposed to do some terminology updates. I think we'll probably do that next meeting at this rate. Any other questions? Milan and Eddie, thank you. Alfonso, Julio, Gerardo, thank you. And we are, again, kicking off our subject matter expert meetings tomorrow, and then we'll come back to you in 2 weeks. So it's the program enhancements is next week. Yes. Next slide. We were supposed to go into some terminology build updates, but I'm going to stop on the SME list. And then because we spent a lot of time on administrative elements. We have a robust set of amazing subject matter experts to help us with incarceration status. We have Andrea Finley, who's a research health scientist from the Veterans Administration. Eduardo, Eddie, how do I pronounce your last name? I want to do it justice.
Bocanegra. You can just also call me Eddie, by the way.
I know, but I respect you, and I want to make sure I call you the right name. Bocanegra, is that correct?
You're pretty close.
Pretty close. Yeah, my G wasn't hard enough. I'll figure that out. Senior Advisor, U.S. Department of Justice. Eileen Gary, Director of Special Projects for the U.S. Department of Justice. Mario Lipschitz, Senior Advisor, U.S. Department of Justice. We have a lot of really innovative leaders from DOJ because of their leadership in this area. Milan Satcher, who along with Radha Satcharadan are the originators of this, because those are the two entities that came up to me at ARM. So Milan is a community and family medicine practitioner at the Giesel School of Medicine at Dartmouth. Is it Giesel? Geisel, thank you. And then, in of all places, Vermont and New Hampshire, I was very excited when she came up to me. Radha Satcharadan's family medicine at University of Washington, Boise, addiction medicine. Sandra Springer is a professor of medicine at Yale School of Medicine, and Tyler Winkleman is a physician division director at Hennepin Healthcare. So all of Milan, Radha, Sandra, and Tyler are all expert physician researchers in the area of incarceration, and we're really, really grateful to have them. There is even one more possible person coming, but this is our list of subject matter experts to date, and we're so grateful for all of them. Really excited. So we kick off our first SME meeting tomorrow. Thank you, all of you. All right, next slide. I think we can just go to homework. I don't think we have time to get to anything. We'll do general updates. So I just want to make sure everyone closes because we only have 4 minutes and understand what's happening next. Next slide. So the Confluence is a great place to go to catch up on anything that's happened. It's a very, very robust, it's like an encyclopedia at this point of all the things that we've ever done. It can be a little bit challenging, but there's always quick picks in the top right if you just want to get links to like our overview slides, figure out what we do and how we do it. For language barriers and incarceration status, this is the normal call to all of you. So if you are aware of instruments that are standardized to assess the either presence of language or communication barriers or incarceration status, please send them to us. You can email them to gravityproject@hl7.org. We've already, Himali Setwal and Sarah Bahal, the amazing terminology team members, we've already spent the summer combing through literature, looking for screening instruments and looking through all basic terminologies to collate what we have so far. But if you have any examples of instruments for either of the two domains, please send them. And then very importantly, bring the programs and the unique professions and people that are helpers in this space. We want to make sure that we name them accordingly. We always build the programs that are of reference and make sure that we have the people of reference as well. You can review the language barriers and incarceration status Confluence pages, where we are going to, all of the materials that we had today should be blooming ever so shortly, and the references link on the bottom in addition to the detailing and bios of our subject matter experts. And we will see you next slide in a couple weeks. You can find us at, well, we didn't change the Sarah and all of our busyness. It has been a busy couple of weeks. Terminology Workstream's no longer bi-weekly. It is weekly. And but it's bi-weekly alternating topics, right? So we'll be back in 2 weeks with incarceration status and language barriers. And then technical workstream, we will figure out the registration. Mike and Lucy, we hear you, and we're going to figure that out and get back to you. That's every other Wednesday from 1 to 2. Implementation on hiatus for August. We'll be back in September on the 26th. All of this can be found on the Confluence. So grateful for all of you. It's 5:29. Thank you for coming to Gravity. Thank you for participating in this critical work to develop a language and tell critical stories. We are so grateful for our subject matter experts. What a really important conversation. It's going to be a powerful work with you over the course of this fall and winter. So team, see you back in 2 weeks, and we'll see you tomorrow. Bye.